Hi, everybody, welcome. Today's discussion is Understanding Music Therapy in Cancer Care, Strategies for Self-Care and Wellness with Dr. Andrew Rossetti. This presentation will give participants a clearer understanding of the scope of music therapy in cancer treatment and post-treatment. It'll provide experimentals and learning experiences on techniques for self-care. Dr. Andrew Rossetti, his PhD, MTBC, and an LCAT, is a clinician educator, researcher, licensed psychotherapist, and the director of the Oncology Music Therapy program at the Louis Armstrong Center for Music and Medicine's multi-site program at Mount Sinai. We are so thrilled to have you. So thank you for joining us. I'm going to make you the co-host right now. So then you are able to share your slides if you'd like, or
Great.
I'm happy to do so.
Perfect. Um, okay, I'm the host. Great. Well, Jillian, thank you so much for the opportunity to speak to this wonderful group. I always love talking about music therapy, and I would like to give you all an idea of what music therapy is and is not. Also, an idea of what we do at the Louis Armstrong Center for Music and Medicine with music therapy. It's a program that's been in place for about 32 years at this point, and we're very proud of our research and our clinical practice. So I'm going to be sharing some of that with you. Also, I have some experientials. Um, I would like to teach you some breathing techniques to be used to relax yourselves when you need to, and a couple of other techniques, bottom up techniques for self regulation. And I'm going to share my screen if I can here. And there we go. So, as I said, we're part of the Louis Armstrong Center for Music and Medicine. And Louis was actually a patient at what is now part of Mount Sinai. It was a hospital called Beth Israel that merged with Sinai about 10 years ago, maybe 10 or 11 years ago. And Louis was a patient at Beth Israel, and he was very, very pleased with the care that he received. And he decided, before he passed on, that he wanted some sort of a program that had to do with music and children. And it just so happened that his publicist, Phoebe Jacobs, met our founding director, Dr. Joanne Lowy, while she was a patient at Beth Israel. And they got to talking, and Phoebe thought that she had found the perfect thing that Louis would have wanted. And that's how the music therapy program started up in what was at that time Beth Israel, with Joanne Lowy working in pediatrics. And we have since grown exponentially. Okay, this is not going to change the way I want it to. So these are some of the locations where we work. Some of them may be familiar to you. That's West. This is Union Square, which is where I am right now. And that is Chelsea. Okay, so as I said, the department has been in existence for about 31 years of providing clinical services, and we are a research-based department. We have about 8 studies going on right now. 2 of those are NIH funded, and another one through the National Endowment for the Arts. So we keep pretty busy with research. We provide at this point music therapy from NICUs all the way through geriatrics and end of life care. And we also have a clinic at Union Square that started out as a clinic to treat musicians, usually for things like substance use, depression, and stage fright. And that has expanded to include now what we refer to as normal neurotics, pulmonary care, children and teens with autism and at high risk, and actually quite a few cancer survivors, some of whom were my patients here in radiation oncology, which is where I do most of my work. And just to let you know that every year we put on a gala to fundraise because we are only partially funded by the Louis Armstrong Foundation. And we put on a very wonderful big gala every year called Wonderful World Friends. Okay, this is our staff. Missing here are interns. We usually have anywhere between 10 and 20 interns every year. Our research fellows are also not in the photo, and our clinical director, who is a psychiatrist, is not in the photos also. Okay. So our theoretical orientation is something called music psychotherapy, and it is about using psychotherapy in conjunction with music and music elements to help patients through treatment and beyond treatment as well. And it is a wellness model, which means that we don't look at just reducing people's symptoms. We try and look at the whole person, and I'll be talking more about that. So we have a holistic view of a person. There are physical aspects, emotional, cognitive, developmental, social, and spiritual. And it just so happens that music is such a wonderfully complex phenomena that it actually touches all of those branches of the human organism. And we also take very strong consideration of traumatization, that's emotional trauma, related to illness and hospitalization in and of itself, what's referred to as medically induced trauma. And I'll speak a little bit more about that as we go along. We use predominantly live music. Live music is much safer than pre-recorded music because we can change it on the right at the moment to meet the needs of patients and to adjust for any sort of non-constructive properties that music can have as well when not used in the right way. We also pride ourselves on having multicultural perspectives in our treatment. So, what is music therapy in the first place? There are lots of things that are labeled as being music therapy that are not. One of the biggest things is that music therapist needs to be carried out by someone who's actually a credentialed professional. And our credentials at this point, it is a bachelor's level starting practice that extends through master's level and doctoral level. And our credentials include licensure from New York State, that's what the LCAT is, and board certification through our Central American Music Therapy Association. So this is done by a credentialed professional, and it is the evidence-based systematic process of intervention carried out, as I said, by a board-certified and licensed music therapist, wherein the therapist helps patients promote health using musical experience and biopsychosocial concepts. So it's not just about music, and it differs from other areas of psychotherapy in that it employs the inherent properties of music and sound as a medium or a moderator for the therapeutic relationship, which is where we believe in our theoretical orientation that therapy takes place, in the relationship that's built between patient or client and therapist. And so music is used in this relationship as a metaphoric or associative element to facilitate change. And music is very much metaphoric. We all know what a metaphor is. It kind of defines in a way what music in itself is, which is a symbolic representation of something other than itself. And music can be used very, very effectively in a process in which it's once removed from the patient, so the patient is able to convey things through music and through song that might be more difficult or impossible to convey just through verbal exchange. So when I'm talking about the song is about me, but it's, as I said, once removed, and that's a little easier. So when asked what music psychotherapy is, sometimes it's kind of hard to do that with words. So here's an idea of what it might look like in pictures. So it's not a literal blending of Sigmund and Ludwig, but a process that uses psychology constructs and strategies, and we are eclectic um, in our learning, in that we employ psychodynamics, humanistic strategies, and cognitive and behavioral therapies as well. So we combine that with music and its elements as a medium and enabler in the therapeutic relationship or alliance. So a lot of what I'm going to be talking about is part of a model that I use in my practice in oncology, and it is called Trauma Resilience and Safety, TRS, and it was part of my doctoral dissertation back in the day. And what this is about is a way of helping patients address illness burden and treatment burden and everything that implies. So, as I said at the beginning, we are a research-based practice. These are some of the studies that I've participated in or run in oncology for the most part. There are some others. And as I mentioned, we have one study going on in depression for teens that is funded by the National Endowment for the Arts. We've also gotten quite a bit of media interest over the years. This was a very nice article that was published in the New York Times, as you can see, with a photo and everything, about what unfortunately they referred to as the healing power of music. That was not my choice for the title. One thing that I think is important to mention is that this is a phrase that's gotten tossed around a lot in the media in recent years. And it sounds great, but the thing is that music in and of itself, there's no empirical evidence whatsoever that music directly heals anything. But there is certainly a lot of empirical evidence that shows that music can be used very effectively in a process to promote healing. So we don't think that we're healing people with music, but we do think that we're helping them heal, not just semantics. This was something that came out in the Mount Sinai Bulletin. That's Dr. Manjit Chadha, who I report to in oncology, and on the right-hand side, actually left-hand side in the photo, is Dr. Joanne Lowy, who is our founding director. Okay, so in my practice in oncology, the patient populations that we work with are inpatient and outpatient oncology, and that is in chemotherapy, radiation oncology, procedural support for surgical procedures. Those are mostly surgery for prostate and OBGYN cancers. We also provide support for brachytherapy and stereotactic radiosurgery. Inpatients receiving treatment for cancer-related comorbidities can be referred to our post-treatment clinic. So as you can see from this, it's a pretty inclusive program. One of the things that we do a lot of work with is this idea of medically induced trauma. So medically induced trauma is something that likely most of you have experienced at one point or another during your treatment for cancer. And the thing about trauma is that not all trauma turns into post-traumatic stress disorder. Many people find that they have resources to deal with trauma directly as it occurs. But we've been doing a lot of work at figuring out the hows and whys to the points of trauma that a person might experience, for instance, during radiation therapy. And we try and set up protocolized interventions that people will get before their cancer treatment so that they have more resources to be able to combat the forces of points of trauma. Okay. So as I said, we have protocols that are thought of as being preventative for medically induced trauma. And it is both a system that is both trauma-informed and trauma-specific. Okay. In inpatient ambulatory oncology, these are some of the areas that I mentioned. Okay, some of the areas of intervention. So what we work with when we're working with patients, often they're phobic responses to some aspect of treatment. In radiation oncology, often people will have phobic responses to getting their first CAT scan, which is something that they get in a process called simulation. This might be familiar to some of you. So we do have an intervention that we provide for patients on their first day of radiation therapy. Okay, we also work with responses that produce high state anxiety or acute stress. We also work with depression, mood disorders, sleep disturbance, which is something very common in many people who are getting treated for cancer, and of course their emotional needs and distress. We also work in pain management with various strategies. So pain is a really interesting phenomena that has specific domains that it occurs in. And one of the domains that it occurs in that is very easy to work with music therapy is the emotional domain. So I'm not talking about emotional pain and suffering, I'm talking about physical pain, physiological pain. There is an emotional part to it. And grossly oversimplified, it means that the better your mood, the less intense your pain experience is likely to be. So helping somebody modulate their mood from feeling sad and depressed into feeling a little bit more hopeful and positive is something that can actually be used in a process to work with reducing their pain. So we also work with this idea of temporal distortion, which is a phenomena that occurs in many waiting rooms at the hospital. I know that many of you have had at some point long waits for your treatment. And there was a study that we carried out about 7 years ago that showed that there was a direct correlation between temporal distortion, which is a distortion of how we experience time, and the level of anxiety that people had. And we found that as people were more anxious in waiting rooms, their sense of time became more distorted. And unfortunately, it was always to feel like they had been spending more time there than they actually had. So we do something called environmental music therapy in waiting rooms to help reduce tension and temporal distortion. And illness burden, treatment burden in general, we look to help people enhance the quality of their life and also sometimes address spiritual needs as well. Okay, there's been a lot of talk as of late about something called trauma-informed care. Trauma-informed care is not the same thing as treating someone for emotional trauma. At the beginning, there was actually quite a bit of confusion into what the two models were. So trauma-informed care is about changing systems in a healthcare system, in a hospital system. And the guidelines for it are the 4 R's, which make it easy to remember. So this is something that we've implemented in our practice in oncology as well. And this is about not just music therapy being informed, but medical staff as well. Okay. We have a referral-based practice, so we don't go room to room soliciting inpatients, and referrals are made by their patients' physicians, nurse practitioners, nurses, other staff, social work, medical and otherwise. There you are, social workers, chaplaincy, patient self-referrals. Okay. And everything we do is based on assessment. And what we do when we assess people is that idea of trying to find out who they were before they became ill. So there's this very interesting phenomena that you might recognize, that when someone becomes seriously ill, there's a change in their persona, and they become a sick person in their minds about themselves. So their concept of self has changed. And we try and find out who the patient was before they became seriously ill, because that provides a lot of perspective on what approach we might use to treat them. And what we assess for is anxiety, pain, general discomfort, what their coping mechanisms might be, the coping mechanisms that they have in place. I have never met a patient who did not have a coping mechanism in place, even on the first day of treatment. So coping mechanisms can be functional or dysfunctional, and they can be functional up to a point. And so if someone has a functional, solid coping structure in place, we don't try and change that unless it becomes dysfunctional, and then we'll try. So we provide look for what their support mechanisms are, their support network, what the patient's understanding and integration of their diagnosis and treatment is, what their prior and current experience with medical treatment might be, what the patient's expectations of treatment are, and other specific needs that they come up with. So I would like to show you I think it's about 8 minutes, 7 or 8 minutes of video of what music therapy looks like in procedural support for chemotherapy. And I'd just like to ask, there's no blood, gore, or anything like that involved in the video, but it is a video of a patient getting chemotherapy. So if there's anybody who would feel like you would not have a particularly pleasant response to viewing the video, you can just sign off for a couple of minutes. Okay. Can you hear the video clearly?
Yes.
So this patient was a Filipino woman at the time, 57 years old, with just listening to the music for a second, with advanced gallbladder cancer. And she had gotten quite a few bouts of chemotherapy and had developed a galloping phobia to needles. And of course, as you know, if you can't get blood draws, you can't get treatment. So I was asked by her nurse practitioner to provide procedural support. All of the music that I'm playing is improvised. So what I'm doing here is playing in the key of the medical monitors that you can hear in the background, and sort of just trying to mirror and reflect what I see in the process. Okay, the music ends. The nurse is unable to get blood out of her port. So she asked the patient to stand up and flap her arms. And my countertransference to that suggestion is what brought up this song, which you might recognize. Blackbird singing in the dead of night. Okay, so the music structured her movement beautifully. Unfortunately, clinically, it wasn't that successful. So we're continuing. So you could hear that I'm trying to play Brahms' Lullaby. You might wonder why I'm trying to play Brahms' Lullaby to a 57-year-old person getting chemotherapy. It's all about the associative process that we have with music. So I was thinking that when she felt most comfortable, perhaps, in her life, was when she was being rocked in the arms of her parents. Okay, you will see an acute stress response from her in a second. That's the first one. The nurse is seeing that, the port wasn't working. She told her she's going to have to draw blood. And you can see that she's quite stressed. The color is starting to drain from her face. She's looking flushed. And her pulse rate is skyrocketing. So I'm using this set of tubular bells that she identified when we first started as the instrument that she liked best of the ones that I had there, because it reminded her of the bells of her church. She sees the needle. Okay. She was close to passing out there. See, she's flushed. Okay, and she and I are playing these set of tubular bells together. If you were able to see her pulse rate, it was very close to this. Okay. So there you see the blood flowing. So you can hear me singing quietly in the background, Flow Like a River.
Can you release my face? Thank you for your
That's about imagery and associations.
That was easy. That was
Okay, so the session's not over. The blood draw was successful. Nurse practitioner is happy, patient is happy. And of course, her music will start to change. Instead of playing one note about this fast, excuse me, she's starting to explore the rest of the instrument. And we're celebrating.
Thank you. Coming from means a lot. Thank you. Music makes me not scared.
Okay. Right. So, we have until 12 o'clock. Is that correct, Jillian?
Sorry, muted. Yes, that's correct.
Yeah, okay, wonderful. So, maybe we could take a few minutes to answer any questions anybody might have about the video, about the procedure. Anybody have any questions or comments?
Janet's hand is up.
Yeah, I have a
Okay.
question. So I have a daughter who has vasovaga, which is like when she takes a blood test, she could pass out easily.
Mhm.
I wonder if this would work for her too, because I've tried everything. I go in with her, I cover her eyes, and just for a simple blood test, she's healthy and everything, but
Mm.
she definitely has that syndrome.
Yes. So, yeah, as a matter of fact, there are a couple of things. One discrete intervention that we use, very very simple but very effective. So the thing is, when somebody has had a traumatic experience with needles or sharps or seeing their own blood, things like that. At the moment that there's that point of trauma, there's some sort of avoidant behavior that occurs. And with injections, I'm sure you've seen this with little kids, and perhaps your daughter did the same thing. When somebody's about to get an injection and they're very frightened of it, they try and get away from it, right? So this is a very primitive form of dissociation, right? So
Right.
the avoidant behavior causes tension, right? And the idea is that trauma lives in the body physically, right? So the idea is if you can stop the tension from occurring, you can probably stop the traumatization or the re-traumatization. The other thing is that the one thing that patients don't have usually in hospitals is control over anything. I mean, you give your consent for the procedure, but that's about it. You can't really stop the nurse from doing anything unless you say, I changed my mind.
Right.
So if we can move the lexus of control over to the patient, it becomes a totally different ballgame, because there's a transition from being a passive recipient of medical care to being a proactive participant. And that changes not just our mental state, it actually changes our physiology as well. Because where the mind goes, body follows. Psyche and soma are one and the same thing. So very quickly, for this procedure, and I don't have a video of this unfortunately, but it's something that I do pretty often. And so this is an egg shaker, right? Makes this sound. So we're not going to use it as a musical instrument. We're going to use it as a medium for a person to release tension. So as you all know, physical tension is relieved by movement, right? And so we're going to inform the patient that they can move the shaker, and the shaker creates sort of a feedback loop, right? And just from the wrist down. So that makes the phlebotomist happy, right? And their arm is, you can't see it now, but usually their arm would be on the armrest of the chair. So that the only thing moving is the wrist. Now beforehand, we've spoken with the nurse or the phlebotomist, and we've explained how we're going to turn over control of the procedure to the patient. And so the patient also is going to learn a breathing technique that they're going to use during the injection or the blood draw. And the nurse knows all about that as well. So it starts off where the patient will take a deep breath, and they will exhale through pursed lips like they're trying to blow out a candle that's all the way across the room. As much pressure as they can. And the nurse is not going to take the blood draw until the patient gives them permission in the moment. And so the patient is prepared to release tension. If they notice any muscular tension, they're going to let it flow down their arm and out into the egg shaker and dissipate. Okay, so they take their deep breath, they say okay to the nurse. The nurse starts to do the blood draw or the injection. They blow out through pursed lips and shake the tension out. Now, that might sound like a ridiculous little nothing, but I've done this literally with hundreds of patients at this point, and for the great majority of them, it's very effective. I've had patients who are absolutely phobic, 100%. They cannot even look at a needle without feeling lightheaded. Being able to, and the other thing is I invite them to watch, because that's really important. Yeah. The interesting thing about blood draws is that we think that things like hand sticks are incredibly painful. The reason that we think that hand sticks and blood draws are painful is most likely because at some point someone has either told us that we have bad veins and this is going to be really difficult, or I'm going to have to do a hand stick, but it's going to hurt. Okay, that sort of suggestion is something that actually um, takes root in us. And if we're told that a hand stick is going to hurt, it's going to hurt. But actually, if we focus on pain, if we focus on hand sticks or a regular blood draw here, and we let ourselves notice what the actual pain is, not all of the other physical symptoms that are part of pain response, like muscular tension. If we just look at the pain of getting that tiny little needle inserted, it's really more of a little ouch than anything else, right? Okay, Janet, I hope that's where does your daughter get
Thank
treated?
you. Well, she's actually very healthy. It's just when she goes for like a yearly blood test. It started when she was 16
Hmm.
at the pediatrician, and she passed out in his office, and it freaked him out
I'll bet.
because she was 16. It freaked me out too because I happened to be in the room and she wasn't coming back. I was ready to do like CPR, and I called the
Mm.
doctor in because he had left for the moment. And then she was fine. And then it happened again at, whenever she takes blood. And she's healthy, knock on wood, but I cover her eyes. I've definitely tried different things. I'm definitely going to try that with the egg. I'll order one. What do they call them? Is it an instrument or
Egg shaker.
okay. Sounds good. Thank you.
Sure, you're quite welcome. Any other questions?
I have a question.
Victoria,
Actually,
yeah.
two. Yes. One is, what about using your voice as an instrument? Um, could that ever be incorporated? Because I think singing really is another thing that lifts you out of yourself, in a way. And someone could sing with you or, choose songs. And the other question is really just about using um, actual instruments live as opposed to listening to music that you particularly resonate with in some way.
Hmm.
And, what about using that? I mean, at this point, I use music in that way. Um, it shifts your mood, um,
Absolutely.
and I'm just really listening to music.
Yeah. Well, thank you for those two comments. Yeah, and both of them are very accurate. So yes, we do use our voice. I mean, it is our primary instrument. The thing is, I'm not that comfortable a singer. I my background, I'm a classically trained guitarist, and for the most part, I like to use guitar as my basic instrument. But yeah, in the video, there's a part where I'm singing quietly. But as part of the process of music therapy, yeah, patients sing, we write songs together, analyze lyrics and such. Um, Instruments that you like, absolutely. So when that's available, unfortunately, here in my office in radiation oncology, it's not a big enough office to have much of anything. So I don't have a piano in the room, which would be great. We do have a piano in our clinic. Um, Lots of drums, percussion instruments, violins, uh, wind instruments as well. And yeah,
There's a lot of very small instruments like triangles and maracas and hand cymbals and that are really fun to
to
work
play, sure,
with.
absolutely. Okay. Other questions? All right, let's move forward. All right, so um, my practice in radiation oncology. This is me working with the patient. Of course, the linear accelerator is not delivering radiation while I'm in the room, and I'm not playing and singing for the patient, but actually playing and doing verbal processing at the same time. Um, At the beginning of the practice, it was actually quite common for patients to have phobic responses, sometimes full-blown panic attacks on their first day of treatment. And I received referrals to work on that, and that's what this photo is from. So very similar to what we do in chemotherapy as well. Okay. We're going to take a look now at some self-care strategies. We have about 15 minutes. Oops, sorry about that. So self-care strategies mostly have to do with one very, very important part of the body, which is our autonomic nervous system. So our autonomic nervous system is what controls all of our bodily functions that we don't have to think about for them to occur. So things like heart rate, blood pressure, respiratory rate, although respiratory rate is to a certain extent controllable. And in turn, the autonomic nervous system regulates the central nervous system. And the central nervous system is what really moves the body. But more importantly is that one of the reasons why music is such an incredibly good clinical tool is that it reaches the body on a completely systemic level, which means pretty much all of the body systems respond to music in one way or another. We know that it activates motor function, movement. We know that it influences directly the limbic system. It influences the part of our brains that process emotion, recall, memories. There's practically nothing that doesn't respond to music. The thing is it is a very, very complex phenomena. And right now, excuse me, lots of people are looking for mechanisms as to why music works as well as it does. And I think that we're still pretty far from understanding it on a direct basis. But we have done a lot of work and found out ways in which music can very definitely help people. So I would like to give you a couple of experientials and then answer any questions you might have. The first experiential is some music-driven breath work. I'm just going to focus this a little bit down further. I have this new function on my Zoom that it doesn't matter how I move around, it'll always focus so that this is pretty much the thing we get. Can you hear the guitar clearly? Okay, it doesn't sound strange like you're just hearing little
No,
bits
it
of
sounds
noise.
beautiful.
All right, fine, perfect. So I thought I'd give you an experiential of a relaxation session with music. Does that sound good for everybody? Okay. I'm going to invite you to close your eyes. If you feel uncomfortable with your eyes closed, of course, you can keep them open. But know that there'll be no surprises or changes while they're closed. And just let yourself focus on the sound of the instrument for a bit. Okay, let's start off with a deep breath, as deep as is comfortable for you. Exhale when you need to. ready? Let's try that once again. Big deep breath. And a long, slow exhale. Perfect. Allow yourself to focus on your breathing, on the physical sensations, what it feels like when you breathe in and breathe out. This is not an exercise, so you don't have to try and breathe in any special way now. Just breathe as your body is asking you to, and observe. Allowing yourself to focus on your breathing, and as you do, you may begin to notice some very subtle, natural physical sensations, almost as if they were a series of events. And likely the first one you'll notice when you draw a breath is the sensation of air flowing into your lungs and your lungs expanding. Just let yourself focus on that one very subtle, natural physical sensation. Air flowing in and air flowing out. Allowing yourself to focus ever more deeply on your breathing. More and more focus, deeper and deeper. You may notice that other thoughts pop into your minds. You don't have to try and block those thoughts out. Just recognize them for what they are and allow them to pass through. And then turn gently back inwards once again, focusing ever more deeply on your breathing. More and more focus, deeper and deeper. You may have noticed that your breathing has changed, that it's now slower and shallower, and likely moved from breathing up in your thorax to breathing down lower in your belly. All signs of a classic relaxation response, all brought about just by you focusing on your breathing. I'm going to invite you to come back to the room. And when you like, you can take a big deep breath and gently let your eyes begin to open. Okay, how was that for you? Great. So, you can do this on your own. And it can be done with music or without music. It's usually a little bit faster and a little bit deeper if music is used. So the way you use music with this is, if you have Spotify can be a really wonderful tool. Pick a piece of music that matches your state in the moment. So if you're activated, feeling lots of energy, whether that be nervous energy or pleasant energy, you need to pick a piece of music that matches that state. So it's not going to be that sort of generic, slow spa music, right? It should be a piece of music that you like. There's not one type of music that works better than another. The most effective music is the music that one likes. So pick a piece, and that'll be your starting off place. You're listening, And you allow yourself to close your eyes, take a deep breath, to long, slow exhale just to get things going. And after that, you breathe as your body is asking you to, just letting yourself focus on the physical sensations with your breathing. Excuse me. Okay, the next piece of music should be something that is slower and less intense sounding. And it can be a piece of music that you like, even if it's a fast piece of music, an energetic piece of music. You just need to find a cover version of it that's slow. And with that as your background, you just keep focusing on your breathing. Usually in about 3 minutes or so, we get a nice relaxation response. But 3 minutes, 5 minutes, whatever it takes. It shouldn't take much longer than 5 minutes. Okay, questions about that? How are we doing for time? We have about 4 minutes. Okay, so let me talk a little bit about pain management. So this is something that music therapy can do a lot with. It's usually better if it's done by a therapist on site and not something that's pre-recorded, because the recordings can't respond to the changes that you're feeling, right? But basically, here's a technique that you can use on your own to manage pain, and it's been shown in studies to be quite effective. And something called focused listening. So when we listen to our favorite music, usually we're listening to the sounds that are in the foreground, right? That's the lead singer. If you listen to pop music, if you're listening to classical music, that's the soloist or the string section, perhaps. And so you're going to try and not listen to what's in the foreground. You're going to try and listen to an instrument that's in the background. Pick it out. If it's pop music, that might be the bass player or percussionist or whatever. Not the lead singer, not the lead guitarist. And let yourself focus on that instrument. Try and follow it all the way through the piece of music. Now, that takes quite a bit of processing power. And in that procedure, our perception of our pain intensity usually diminishes. Very, very easy to do, and you can do it for as long as you need it. Right? I wanted to talk a little bit about sleep hygiene just really quickly. Since some of the patients that I've worked with in oncology at some point have difficulty sleeping or actually have significant sleep disorders. And so really easy to do. Anybody have difficulty sleeping? Yeah, okay, I can raise my hand as well. So for sleep hygiene, first off, no screens for at least an hour and a half before you go to bed. So no computers, phones, TV. The next thing, the bedroom is for two things, for sleeping and for intimacy. So there's no eating, no watching TV, no reading in your bedroom. You're conditioning your body and your brain to, when you enter your bedroom, you're ready to sleep. Okay? So we also try and avoid having meals about 3 hours before we go to bed. And your bedroom should be cool and dark. Okay, all of those things. If you experience this, as many people do, there's this phenomena that around 3 o'clock in the morning or 3:30, and it doesn't really matter what time we go to bed, but around that time, people notice that they're awake and they become aware of an unpleasant thought that sort of cycles around. Other unpleasant thoughts seem to join it, and getting back to sleep becomes impossible, even the idea of it. So there's a technique that you can use, which is the following. Recognize that the thoughts that you have are likely valuable. They're your thoughts. They're not something to be thrown out. They're not something to be avoided. And that usually they're thoughts that have something to do with meaning making, with solution finding. Okay, the time to identify the meaning of things and find solution for things is not 3 o'clock in the morning for most people. So what you're going to do is tuck them away for safekeeping until it's an appropriate time to work on them. Maybe 10:30, 11 o'clock in the morning, which is when we are fully functional and revved up with lots of energy. So you're going to take those thoughts, identify them, and you are going to put them in a little container or compartment for safekeeping. And visualize the compartment. You can be as elaborate as you want on that. Its color, its texture, its weight, what it's made out of. And your container or compartment has a key or a lock of some sort. The only person that has the key or the lock, the key to the lock or the combination, is you. So you're taking them, putting them in this container, closing it, locking it, and you're going to put it away somewhere, on a shelf, under the bed, in a suitcase, wherever, for safekeeping. And then you're going to do a little bit of this breathing exercise and let yourself start to feel drowsy. In the morning, when you wake up, that'll be the time for you to work on your thoughts, right? We don't usually wake up with really pleasant thoughts. We wake up at 3 o'clock in the morning usually with really unpleasant thoughts. Okay, so if we have some final questions. These are some of our publications. And if you would like to get in touch, that is my contact information.
Thank you so very much.